This is Dr. Saad in front of you, and today my topic is the esophageal motility disorders. As we were discussing this topic previously and we have discussed achalasia from this topic, now the further topics that are the diffuse esophageal spasm, nutcracker esophagus, Zenker diverticulum. These are very short topics and we will cover it in a few minutes, and we will be discussing only the management as we have discussed their pathology in our special pathology lectures. And if you want to remember them, you can see in my videos, and you can see the link in the at the top of this video. Clear? So now we are moving on towards our second disease after achalasia. We are moving on towards the diffuse esophageal spasm. Now I am going to tell you the management of this. So how you will, first of all, in the management there are two things. One is the diagnosis, then we have the treatment. So how you will diagnose this diffuse esophageal spasm? So first of the investigation in this condition is the barium swallow. Now what you will see on the barium swallow, in the barium swallow you will be observing an appearance that is called as the corkscrew appearance. Now what is this corkscrew appearance? This occurs because of the, you can say, discoordinated contraction, discoordinated diffuse contraction. Now this is, for example, your esophagus, and in this way you will see the contractions. Diffusely it is contracted. See, this is the contractions and this is just the corkscrew appearance, or you can say rose beaded appearance. Here you can see these are the beads like this. This is the rose beaded appearance. These are the beads. Clear? So this is the diagnosis, the barium swallow, and the barium swallow you will see the corkscrew appearance like this. It appears like black colored here. Clear? Then we have the second investigation for the diffuse esophageal spasm, that is the manometry. Manometry, you will see on the graph there will be high amplitude waves will be there, and you can say recurrent high amplitude waves, peristaltic contractions will occur, and they are of 40 millimeter to 50 millimeter of mercury. Clear? On the manometry. So these are the two investigations for the diffuse esophageal spasm. These are the very short topics, just covering it quickly. Then we have the second one, that is the nutcracker esophagus. Nutcracker esophagus. In this, the investigation means the diagnosis is also same, that is the manometry. You will carry out the manometry. Clear? In manometry you will be seeing the high amplitude waves will be there, and that will be of greater than 180 millimeter of mercury. Clear? Now the treatment of both, they are same. Clear? Now I am writing here the treatment. As there is the distal part of the esophagus, in both the condition it is contracted. Clear? So how you will overcome the contraction? So there are treatment options. Number one, you will give the calcium channel blockers. Clear? First of all, you will be giving the calcium channel blockers. You can also give the nitrates. You will be carrying out the pneumatic balloon dilation. Means you will insert the balloon and dilate that part of the esophagus. Then after that you can do the surgical myotomy. Clear? These are the treatment options for the diffuse esophageal spasm and the nutcracker esophagus. Now the last esophageal motility disorder that we are going to discuss is the Zenker diverticulum. Clear? That is the Zenker diverticulum. Third one, that is the Zenker diverticulum. What is this Zenker diverticulum? You all know that it is basically most common esophageal diverticulum, that is, you can say, protrusion of the esophageal part from the cricopharyngeus muscle. Means between the cricopharyngeus muscle there is a weak point that is called as the Killian's dehiscence. From that part the esophageal part is protruded out like a form of the pouch, and that is called as the Zenker diverticulum. Clear? Now what is basically, I have to my main focus is the management. So what is the management for this? For the management, we will first of all carry out the diagnosis. Diagnosis is once again the barium swallow, and this barium swallow is the investigation of choice in this condition. You can easily diagnose Zenker diverticulum by the barium swallow, and you won't do the endoscopy in this condition. Try to not do endoscopy in this condition because there are many chances of the perforation of that pouch. So you have not to do the endoscopy, you will be carrying out the barium swallow. It is the investigation of choice. Then the Zenker diverticulum, how it is treated? So very easy. Obviously there will be the surgical treatment, surgical resection. Clear? There will be surgical resection. Now, so this is the esophageal motility disorders in which we study the achalasia, diffuse esophageal spasm, nutcracker-esophagus, Zenker diverticulum. This is all about the esophageal motility disorder. Now we are moving on towards the esophageal inflammations and the infections. Clear? Let me erase it. So this is a new topic because this topic was short, so I thought that I would teach you the other topic too. So that is the esophageal infections and inflammations. Clear? Now in this topic there are further 4 subtopics that we'll be studying one by one. So just remember, one is the GERD. We'll be studying the management of these, as we have studied this topic in the special pathology, but now main focus will be on the management. One is the GERD, second is the hiatal hernia, third is the infectious esophagitis, and the last one is the Barrett's esophagus. So these are the 4 subtopics that we will be discussing one by one, and in today's lecture just we will be focusing on the GERD, one topic. Okay, now GERD is a very important topic, very common disease, and this is theoretically also very important and practically it is also very important. At least you must know that what you have to do to a GERD patient. Clear? So GERD, gastroesophageal reflux disease, means the stomach contents, they reflux back into the esophagus. Now moving on, just I am focusing the management, as we have discussed it many times in our previous lecture. That's why I am going to the management. Now for the management, first of all, first condition is you have to do the diagnosis. So first of all, in the diagnosis you will do the endoscopy. Endoscopy is done, there are conditions to do the endoscopy, means you cannot do endoscopy in every patient. Why? The reason is that, the reason I am telling you that when the endoscopy is indicated, you will understand that what are the reasons. Then the endoscopy is indicated when the patient fails to respond to the PPIs. When the proton pump inhibitors they fails, means that when the patient failed to respond to the proton pump inhibitors, then you will do the endoscopy. First indication. Second indication, you have to do the endoscopy in a patient greater than 55 years old. 50 to 55 years old. If the patient is older than this age or he is of this age, you have to do the endoscopy. And this patient, he is complaining you of the dysphagia, he is complaining you of anemia, he is also complaining of the weight loss. Clear? And his fecal occult blood test is also positive. So this is an alarming situation, means in this condition you have to carry out the endoscopy very immediately, so that you can reach to the diagnosis and you can carry it out, you can start the treatment means as soon as possible. Clear? So this is the indication for the endoscopy. Means first of all you have to give the PPIs, the patient fails to respond to the PPIs, then you have to do endoscopy, and in these conditions you have to do the endoscopy. Clear? Now what happens that you have done the endoscopy and the endoscopy is also normal and still the diagnosis is uncertain. Clear? This is your option. Still the diagnosis is uncertain. So now what you will do, you have also another option, that is the manometry. In manometry there is decreased lower esophageal sphincter pressure. Clear? Then most accurate investigation is the 24-hour pH monitoring of the patient. This is the most accurate investigation. Remember this thing. Most accurate investigation, 24 hours pH monitoring. Clear? So this is your diagnostic, means what are the investigations that you will be carrying out. Means first of all, PPIs. If the PPIs, the patient not responding to the PPI, you have to do the endoscopy. And if the patient having these features with the age of this, you have to do the endoscopy. Now if the endoscopy is normal and still you have not reached the diagnosis, then you can carry out the manometry, in which you will be observing this decreased low esophageal sphincter pressure, and most accurately there is 24 hours pH monitoring in that patient. Clear? Now moving on towards the after diagnosis, we have the treatment, that how you will treat the patient. So first of all, the treatment you will give the patient, you will teach the patient to modify his lifestyle. So the first option, you can say that it is the lifestyle modifications. Means what you have to tell the patient, you have to tell the patient not to eat the heavy meals at the late night. One thing. Clear? You have to tell the patient that prevent from the precipitating factors of the GERD. Clear? So, and you have to tell the patient that he must keep his head in the upright position, or you can say his head must be in a higher position than his body, so that the means contents may not reflux backward due to the gravity. Clear? So head must be in this position, patient must lie in this position. This is your head and this is your body, so head must be in this position and the body must be in this position. Clear? So these are the lifestyle modifications in the patient. Now what is the treatment algorithm? Means what are your treatment plan, that how you will start the treatment, what you will do in the treatment. So first thing, if a patient is coming to you, clear, and he is for example 25 years old or 30 years old, he is coming to you with the heartburn, pain in epigastrium and all that, just you have to start, first thing you have to do is you have to start the PPIs. Proton pump inhibitors must be started in that patient. Clear? So you have to start this PPIs. Now after that, you have to monitor the patient for 2 to 3 months, that if he is responding to the PPIs or not. If the patient, now you have given the PPIs, first option, first thing you have done is you have given the PPIs. Now after that, you have to see that if the patient responds good to PPI, if the patient responds good to the PPI, then what you have to do, then you have to maintain PPI dose. Means you have to continue the PPI with a maintenance dose. Clear? This is your one option, means if the patient is responding good. If the patient respond bad, or you can say poor response to the PPIs, then what you have to do, that if the patient he is not responding to the PPIs, so what you will be doing, you will be doing the 24-hour pH monitoring. In this condition, in the bad or the poor response, you will do 24-hour pH monitoring. Clear? Now in this condition, if you are observing the patient and the result of this, if what happens that if the patient pH is positive, means it is acidic, so you have to do the surgical fundoplication. Surgical fundoplication we will be studying in surgery also, but I am telling you that in this the surgeon basically create a sphincter of the muscle in the lower part of the esophagus. The surgeon creates a sphincter of the muscles of the esophagus, so that the gastric contents cannot reflux backward. This is the surgical fundoplication, and this you have to do when the patient pH is positive. After 24 hours monitoring, the pH is positive, it is acidic, you have to do the surgical fundoplication. But if the pH is negative, so you have to reconsider the diagnosis. Clear? Now this is your pH monitoring. Now we are moving on that what type of the drugs you are going to give. What means the type of the drugs that are you are going to give is the, you can say, pharmacologic treatment. Pharmacologic treatment, first of all, I told you that is the PPIs. Now what type of the PPIs you are going to give, or which PPIs? Very easy. You have heard many times omeprazole, lansoprazole, then you have the esomeprazole. Now we are studying the medicine, as we are studying the medicine in final year, so we have to remember these names of the drugs too. Clear? Now these PPIs, basically you all know that they inhibit the hydrogen potassium ATPase pump. Clear? They inhibit the hydrogen potassium ATPase pump. And what these PPIs do, these PPI decrease the symptoms and also prevent the esophagitis. Means due to the GERD, when esophagitis occurs, so the PPIs means prevent the symptoms also, and they prevent the esophagitis. Means the effect of the PPIs is on the symptoms as well as on the esophagitis as well as on the inflammation. Clear? Simple is that. Then these PPIs also have certain side effects. We have certain side effects. Mean when the PPIs are used for a longer period of time, then they are having certain side effects that are, for example, we have the diarrhea, we have headache. Clear? Certain types of the side effects are seen in the PPIs when they are used. And we also have the Clostridium difficile infection can also develop. We also have the vitamin B12 deficiency and iron deficiency. Why? Because PPIs can cause the decreased absorption of these substances. So these are the side effects for the when they are used for the longer period of time. Clear? Now the second types of the drug that we are using in this condition is the H2 antagonist. Second pharmacological drugs we are using is the H2 antagonist. Now these are the histamine 2 receptor blockers, and how they work, basically they you can say they block the action of histamine on the parietal cells. What? They block the action of histamine on parietal cells. So what happens, that the parietal cells, they do not secrete the acid. In this way the acid secretion is decreased, and when the acid secretion is decreased, so the acid free you can say the gastric contents, when they move towards the esophagus, so they will be causing less damage. Clear? When the acid free contents of the gastric means stomach contents, they move into the esophagus, they will be causing less damage because they are acid free. So that's why we are decreasing the acid concentration here. Clear? This I think so I have told you in the previous lecture too. So these are the H2 receptor antagonists, and how they work I told you. Now what are those? You all know that are the cimetidine, famotidine, clear, razotidine. These are the H2 receptor antagonists. They are the name of the drugs. Clear? Now one thing, that the PPIs were affecting the symptoms as well as they were preventing the esophagitis, but the H2 receptor antagonist, they affect or decrease the symptoms but do not affect the esophagitis. There is no role of the H2 antagonist in preventing the esophagitis. Is that clear? Now we also have certain side effects for these for the H2 antagonist. They are same, the headache, diarrhea occur, and especially if you are asking for the cimetidine, so gynecomastia occur in the cimetidine used for the prolonged time. Clear? So this is the pharmacological treatment of the GERD, PPIs and the H2 antagonists. What are those? What are their side effects? How they are, means what is the mechanism of action, and means which part they affect. Means symptoms are decreased and the esophagitis also decreased. In this there is no effect on the esophagitis, H2 antagonist. Then after pharmacological treatment we have the surgical treatment. Surgical treatment we will be discussing in detail in the surgery lectures, but when the surgery is indicated, I am telling you the indication of surgery is when the medical treatment is failed. Clear? When the patient refused to eat the prolonged means PPIs. Clear? When there is the Barrett esophagus is developed, so we will be doing the surgical treatment, that is the laparoscopic procedures, and that will be discussed in our surgical lectures. So we have, up till now we have discussed everything about the management of the GERD. If you have any question, any query, you can ask in the comment section. Thank you so much. Allah Hafiz.